Hello everyone, welcome to a new video by Phoenix Medical Lectures. In today's video, we'll be seeing about rheumatoid arthritis. So the last video was about osteoarthritis and that was a degenerative condition, whereas rheumatoid arthritis is an inflammatory arthritis and it is the most common type of inflammatory arthritis. So this involves the synovium. This mainly involves the synovium, whereas osteoarthritis, we saw it involves the articular cartilage. This is an autoimmune multi-system disease. It involves the heart, the lungs, the liver, not only the joint, but it has predominant musculoskeletal involvement. This is an erosive type of arthritis, which means it destroys the joint. This is helpful in differentiating rheumatoid arthritis from systemic lupus erythematosus, which is not erosive. It doesn't destroy the joint. So, females are more affected than males. This is same for osteoarthritis as well. Again, so there's a symmetrical peripheral joint involvement. So symmetrical, which means bilateral joint involvement, both the sides of the joints are involved, and peripheral, which means the joints of the arms and the legs are predominantly involved. So coming to joint involvement, in the previous video we had seen what are the joints that are involved and spared in rheumatoid arthritis and osteoarthritis. So here we'll be seeing about rheumatoid arthritis. Again, we'll revise it. So MCP, metacarpophalangeal joint, is the most commonly involved joint in the rheumatoid arthritis pathology. The thing is, this MCP is spared in osteoarthritis. So what is the most commonly involved joint in osteoarthritis is the distal interphalangeal joint. That is spared in rheumatoid arthritis. So apart from this, what are the other joints that are involved? The wrist, the proximal interphalangeal joint, knee joint, hip joint. These are the most commonly involved joints. Sometimes the axial region might also be involved, though it's very rare, which is the C1, C2 subluxation, the cervical spine. Coming to the pathology. So when it comes to rheumatoid arthritis pathology, we need to remember two main things. Already we know it is the destruction of the synovium, it is an erosive disease. The main two features that we're going to remember in the pathology part is immune complexes and pannus formation. These are the two main things that we're going to remember. So since we already know that rheumatoid arthritis is an inflammatory condition, there will be formation of immune complexes. One thing. The another thing is, since it is an inflammatory condition, there's always going to be increase in blood supply. So when there's increase in blood supply, there is going to be abnormal proliferation of microvascular structures. So when there is abnormal proliferation of microvascular structures, that will lead to pannus formation. So there's pannus formation. That is one pathogenic feature. Second one is immune complexes. So there is an antigen antibody complex. It is an inflammatory reaction. So these immune complexes will cause a blockage to the blood supply. So that will lead to necrosis. When there is a blockage to the blood supply and there is necrosis, it will lead to the subluxation of the joint. We already had seen the structure of a synovial joint. There's a capsule, there's articular cartilage, and there's synovium. So the main part that is affected in rheumatoid arthritis would be this part, the synovium. So a quick recap of what we saw. This is an autoimmune disease. So there's antigen antibody reaction which leads to inflammation, and then there's destruction of synovium. So how does this occur? Due to inflammation, there will be an increased blood supply. So increased blood supply, microvascular proliferation, that will lead to abnormal fibrovascular growth, which is called pannus formation. And this pannus formation occurs from the periphery to the center. Next is immune complexes. This leads to blockage of blood supply. that will lead to destruction of the cartilage and further lead to subluxation of the joint. Another important term that we see or we come across in rheumatoid arthritis is fibrous ankylosis. So basically, ankylosis means fusion of the joint. So there's fibrous tissue and fusion of the joint in rheumatoid arthritis. Again, this differentiates rheumatoid arthritis from septic arthritis. Septic arthritis also has ankylosis, but this ankylosis is bony ankylosis, whereas in rheumatoid arthritis it is fibrous ankylosis. So what are the other associated diseases would be carditis, pleuritis. We already saw there's lung and heart involvement. Okay, so there's something known as the Kaplan syndrome. We're going to see two syndromes, Kaplan syndrome and Felty syndrome. So first, the Kaplan syndrome. This is also known as rheumatoid pneumoconiosis. So this occurs in people who have rheumatoid arthritis and have been exposed to some kind of dust, which is coal, silica, normally which causes pneumoconiosis. So what happens? There'll be inflammation, swelling of the lungs, and then finally there'll be scarring of the lungs, like when we can see in this X-ray. And then coming to Felty syndrome. Felty syndrome is a group of disorders associated with rheumatoid arthritis. Two main features, there'll be splenomegaly. Mainly, there's an enlarged spleen and the blood counts are decreased. So there'll be anemia, neutropenia and thrombocytopenia along with arthritis. Then we call it as a Felty syndrome, and this is the mnemonic for Felty syndrome. Coming to the diagnosis, two main things. There's a sensitive marker, there is a specific marker. So the sensitive marker is rheumatoid factor and the specific marker is anti-CCP, which is anti-cyclic citrullinated peptide. So there's a sensitive marker and there is a specific marker. Apart from that, there is elevated CRP and ESR, acute phase reactants. What are the poor prognostic factors when it comes to rheumatoid arthritis? An increase in the rheumatoid factor, CRP, ESR. Subcutaneous nodules might be present. Erosions on X-ray that we see, it is an erosive disease. And if the symptoms persist for more than a year, there's history of symptoms for more than a year, then it leads to a poor prognosis. Coming to the X-ray features, main X-ray features, it is an erosive disease, so there is marginal erosion. Okay, there is marginal erosion and there is narrowing of the joint space. Apart from this, there is osteoporosis. This osteoporosis, initially it is juxta-articular, but later on it will be generalized. So what all we saw before, narrowing of joint space, osteoporosis, marginal erosions, but no sclerosis or osteophytes. There was osteophyte formation in osteoarthritis, but it is not there in rheumatoid arthritis. So what are the deformities? So we divide these deformities into hand deformities, knee deformities and foot deformities. So in the hand there's swan neck, boutonnieres, Z deformity. In knee there's genu valgus, windswept and triple deformity, whereas in the foot there's hammer toe, hallus valgus and windswept deformity. So we'll be seeing one by one. So coming to the hand. In the hand there's three main deformities. The first one that we're going to see is the boutonnieres deformity, and next we'll see about the swan neck deformity. Both of these deformities involve the proximal interphalangeal joint and the distal interphalangeal joint. Although we had already seen that distal interphalangeal joint is normally generally spared in rheumatoid arthritis. So why is it involved in the deformity? First we'll see the boutonnieres deformity. There is flexion of proximal interphalangeal joint. That is the deformity. But due to a compensatory mechanism, the distal interphalangeal joint has to undergo extension. So distal interphalangeal joint is not primarily involved in the deformity. It is just a compensatory mechanism. Coming to swan neck deformity, it is just the opposite. The proximal interphalangeal joint undergoes extension, so the distal interphalangeal joint has to undergo compensatory flexion. These are the two deformities. Another deformity of the hand is the Z deformity. So Z deformity is when there is radial deviation of the wrist and ulnar deviation of the fingers. This is the Z deformity. So we saw all the hand deformities. Coming to knee, there will be genu valgum. So valgus deformity is seen in rheumatoid arthritis. So valgus is when the leg portion, it is away from the midline, as we can see in this image. There's another thing known as genu varum, wherein the leg is towards the midline, and this occurs in osteoarthritis. In rheumatoid arthritis, there is valgus deformity. Another deformity that occurs is windswept deformity, wherein one knee has varus, whereas the other knee has valgus. So it is in this pattern, windswept deformity. So when there is this deformity that occurs in the knee, then if it occurs in children, then we primarily suspect rickets. But if it occurs in adults, then the primarily suspected disease will be rheumatoid arthritis, this windswept deformity. But if windswept deformity is occurring in the foot, then the primarily suspected disease would be rheumatoid arthritis. Coming to the foot. So in the foot, there's something known as the hammer toe deformity, where the proximal interphalangeal joint is flexed. Finally, coming to the management. First, physiotherapy. That is the first thing that we're doing. Commonly that we do along with the medical management is physiotherapy. So what is the drug of choice? That is methotrexate. Methotrexate is the drug of choice for rheumatoid arthritis, but it is contraindicated in pregnancy. So 3 months before planning for pregnancy, this drug should be stopped since it is proven to be teratogenic. So if someone's using methotrexate and then they're not yielding the effects of methotrexate, then the second option that we try is DMARDs, which is disease modifying anti-rheumatoid drugs, which includes sulfasalazine, hydroxychloroquine. Apart from these, the other drugs that we use are immunosuppressants such as leflunomide, and then TNF alpha inhibitors like infliximab and adalimumab, and then interleukin-1 antagonists like anakinra, and anti-CD20 receptor antibodies like rituximab. So surgical management, there is synovectomy, there can be joint replacement can be done, and finally deformity correction can be tried. Thank you.